You're listening to Talking Points with Preferred Health Magazine. On this amazing show, you get a VIP look at interviews with some of today's beloved celebrities, book authors, top physicians, and leaders in the healthcare industry. So stick around, you're not going to want to miss what's next.
Hi, and welcome to Talking Points with Preferred Health Magazine. I'm your host, Laura Polina, and on today's show, we will be speaking with patient-preferred bariatric surgeon, Dr. Michael J. Sutker, who practices in Dallas and McKinney, Texas. Dr. Sutker has over 7 years of experience, and we're here to get his expert advice about getting surgery for weight loss and talk a little bit about the obesity epidemic, which remains in this country. So welcome to Talking Points, Dr. Sutker.
All right, thanks for having me today.
Yes. All right. So let's jump right into it. So we're hearing more and more about bariatric surgery as those who are overweight are now trying to live a healthier lifestyle and have options available to them. So can you tell us about the two surgeries you perform for weight loss and how they differ between the gastric sleeve and bypass?
Okay. So there are two main operations that we do for weight loss surgery, that being the sleeve gastrectomy, which is right now the most popular operation in the United States, and the gastric bypass. Bypass being our gold standard for about the last 35 to 40 years. The sleeve has become a lot more popular over the last 10 to 15 years. Both are great operations, and typically there's not a good operation and a bad operation. Most people are successful either way. Normal anatomy of a stomach is basically our stomach is a reservoir. It's a sac that expands as we eat food. And what the surgeries do is they essentially decrease that reservoir. And so you have less of an area, less of a volume of food that you can eat. But what's interesting about these surgeries compared to someone who just wants to diet and just says, I'm going to eat less, I'm going to have less calories, I'm not going to eat as big of a meal, the surgeries actually change your hormones. And so those hormone changes take away your appetite, meaning you're not hungry, and then they make you full quickly, what we call satiety. And so even though you're eating a small amount of food, you feel full quickly and then want to stop eating. So that whole combination of things, so you're not hungry, you can't eat that much food, and then you get full quickly, all of those are what help contribute to the weight loss. So that's kind of the general principle behind how the operations works. The difference between the operations, it's a technical difference. So with a sleeve, we take that big sac and turn it into a thin tube, a sleeve, and so the volume of the stomach is decreased by about 80%. And we're actually physically removing about 80% of the stomach. With a bypass, we're not actually removing any portion of the stomach, but we're creating a small pouch at the top so that you have a small area to capture food, and then rearranging or bypassing the intestines to connect directly to the pouch. So food goes through your pouch directly into the intestines. As I said, there's pros and cons to each operation, and we do try to tailor the operation to each individual person.
Okay. So, who qualifies for these types of surgery if they're looking to live a healthier lifestyle, and who wouldn't necessarily?
So the very simple answer is anyone with a BMI of greater than 40 is considered a good candidate for surgery. BMI, or body mass index, is a term we calculate based on your height and your weight. There's lots of calculators you can look online. Just plug the numbers in and it'll kind of tell you. Now, BMI is not a perfect number. If you look at any professional football player, their BMI is going to be 33, 35, 37, but that's because they're all muscle. But in general, it's a good term that the government uses, that insurance company uses to kind of get a good baseline. So just to review, so anyone with a BMI greater than 40 is considered a candidate for surgery. Anyone with a BMI of 35 to 40 may be considered a candidate for surgery if they have evidence of what we call metabolic disease. So something like high blood pressure, high cholesterol, heart disease, diabetes, sleep apnea, and arthritis are typically the big medical problems we see. So anyone with a BMI of 35 to 40 with one of those diseases, they are also a candidate for surgery. Lastly, we are also seeing evidence that people with diabetes can also get resolution of their diabetes if they have a BMI of 30 to 35. That's still more investigational, but we're seeing really good results, even better than what medication can do.
Oh, interesting. I have not yet heard about the diabetes candidate. So that's a very interesting point. So it could really help with their diabetes as well.
Yeah, we call that more of metabolic surgery as opposed to bariatric surgery in that range. But as I said, we've seen really good results even with the lower BMI patients.
Nice. Okay. And then between gastric sleeve and bypass, are there certain degrees that you look at, or is it really just personalized to the patient?
Yes and no. I have a lot of patients who say, well, I had a friend do this and they had good results. That's what I want done. Or I had a family member who did this and they weren't as happy with the results. So I want the other thing done. So that's definitely a lot of it. But in general, I am more prone to recommending a bypass for people with poorly controlled diabetes, people with a higher BMI, so people with a BMI greater than 50, or people with really bad reflux. So I think those are the biggest indications for me to recommend a bypass over a sleeve. Beyond that, pretty much it's kind of, we talk about the risks and the benefits of each, and I kind of help the patient just decide one over the other.
Oh, sure. Okay. And so I know there are protocols for the surgery, like blood tests and physicals. Can you kind of walk us through what they need to do for that? And then also how patients can prepare also emotionally for such a big life-changing surgery?
Absolutely. So the requirements to get from a visit with me to the operating room are driven both by your insurance, by national guidelines, and then by what I think is necessary to be able to perform safely. And ultimately, the guidelines are in place because number one, we want to make sure you're successful with surgery. And number two, we want to make sure that we're doing surgery safely. Mm-hmm. And so everybody needs evaluation by a primary care doctor, an internist, basically someone besides me, the surgeon, who says, we think surgery is a good idea. The second part is getting a nutrition evaluation. And this is usually what is the limiting step to getting into the operating room. Every insurance company is different in terms of what they require. Some companies require one visit, some require 12 to 24 visits.
Oh.
And so it just varies, but we always, talk with the insurance company and see what they require. And that's to help get the education so you know what to expect both before surgery and after surgery in terms of what the dietary recommendations are. Everyone has a psychological evaluation. Make sure there's no eating disorders, substance abuse disorders, undiagnosed mood disorders, things that would impair your recovery from surgery, because surgery is such a big lifestyle change. And then on top of that, we want to make sure that your medical problems are okay. So we're looking at lab work, making sure you don't have any undiagnosed high blood pressure, undiagnosed high cholesterol, undiagnosed diabetes, kidney disease, and then certain things like getting an ultrasound to look for fatty liver disease or gallbladder disease. Depending on your medical problems, you may need a cardiac evaluation, a heart evaluation, a pulmonary evaluation, like a sleep study to look for sleep apnea. And then depending on if you've got reflux or a hiatal hernia, you may also need to see a GI doctor to get an endoscopy or an upper GI, look for those sorts of things. And then the last big part for me with my patients, I really want to make sure everyone's up to date with their general health maintenance. So if you're due for a mammogram or a colonoscopy, something like that, we want to make sure you're up to date with that, because we know obesity is associated with a lot of cancers that we pick up with those routine health screenings.
So it sounds like there are quite a few steps from the initial meeting and decision to the surgery. How long of a time frame is that usually?
It can typically be as short as about 6 weeks, and sometimes it takes up to 6 months.
Mm-hmm. Okay.
Yeah, as I said, the biggest thing is just those nutritional visits. If your insurance company requires 12 visits, unfortunately, I have no say and I can't push that forward, and it may take you 12 months. If it's only 2 visits, then that's 2 months.
Nice. Yes. Okay. So, excuse me, what would you say to a patient who wasn't quite sure if they wanted to go through with the bariatric surgery, even though it could change their life? So they know it's a good idea, but they're kind of emotionally stuck in making that big decision.
So it's not uncommon that a patient is skeptical or their family is skeptical and they want to get more information. And so I actually do a lot of education with my patients. I have everyone watch a video where we go into all of those risks, the benefits, et cetera, and go into it in a lot more detail. And doing that education answers about 90% of questions, because if someone's asking it now, it means I've probably gotten that question in the past. And usually when I explain to patients, surgery is not to look good. It's not just to get your waist size down and say you want to fit in a better pair of pants. It's you want to have more energy. You want to be able to go play with your kids or your grandkids. You want to stop taking your medication for your diabetes or your high cholesterol. You want to be able to go on to have your knee replacement or your hip replacement. So those people with very discrete goals that can't achieve those because of their weight and because of their medical problems, that's really the most convincing argument for surgery. It's not just saying I want to be at a better weight. It's saying, well, if I get to a better weight, I can do this instead. And that's usually the most convincing argument that I have for patients, is just to have a better lifestyle, a better life, because all of these other things are getting corrected at the same time.
Yeah, definitely. That makes so much sense, that so much of your life can change from it, not just your look. So that leads me to my next question. And there was a study published in the Journal of American Medical Association last year that found out of the 948 people surveyed, 49.4% thought that the most people had weight loss surgery for cosmetic reasons, and 39.1% thought that people who had weight loss surgery chose the easy way out. So what can you say about these perceptions?
Number one, surgery by no means is easy. It requires a lot of work. It requires a lot of lifestyle changes. And in many aspects, it's harder than doing a diet, because honestly, a diet, you can stop anytime and go back to old habits. After surgery, you can't just stop what you're doing and say, I'm going to go back to doing what I did before, because you're just not capable of doing that. And there's lots of side effects involved. So surgery by no means is an easy way, is an easy route, is skipping ahead. And the other thing we know about surgery compared to, what we call medical weight loss or medical management, is surgery has much, much better results, both in the short term and the long term, for those medical problems. And so why wouldn't you want to do something that gives you the best chance of success? So that's kind of the big thing there, as opposed to it being just a cosmetic. I mean, that's unfortunately, that goes a lot along with obesity bias. There's lots of, advertisements, public perception, et cetera, that obesity is a shortcoming, it's a failing, it's a personal problem, which is really not the case. Is our bodies biologically develop methods to prevent us to lose weight. And so even with diet and exercise alone, the vast majority of people aren't successful. I think the numbers are less than 10% of people are successful long-term with diet and exercise alone. And I can tell you 90% of people are really trying, aren't just giving up and having personal failings, is they're trying really hard to do it, and their bodies are just saying, no, we're not going to let you do that. And that's where surgery comes in. Surgery is a just much more powerful tool.
Sure. That makes so much sense. Okay. And can bariatric surgery be covered by health insurance? And if it's not, should it be?
The answer is yeah, absolutely. It is, especially in Texas where I live, only about 30% of people actually have coverage for bariatric surgery, which is really frustrating, because there's a lot more people than that who would benefit from surgery. If you look from a purely economical standpoint, long-term, over the course of someone's life, people who have surgery cost less healthcare dollars than someone who is obese but doesn't have surgery. So absolutely, it's something that should be covered. That being said, it is not covered by a lot of insurance companies. Medicare and Medicaid both cover it as a weight loss option, and a lot of private insurances do cover it. Anytime you go for evaluation, whether it's with me, whether it's another surgeon, part of the process is evaluating with your insurance company to see if you do qualify or not. Even if you don't have coverage, there are cash pay options, there are financing options, et cetera, that unfortunately, we don't want financial barriers to prevent you from getting, the procedure that you need. And so we try to work with you as much as possible to get that done.
So if someone didn't have insurance and they're considering the surgery, what would the financials look like for that?
Honestly, it varies. It really varies based on the facility, based on the procedure. It's not just, unfortunately, it's not just the surgeon fee, it's the facility fee, the anesthesia fee. There's a lot of things that go into it. So it makes the cost very dependent. And so it's honestly, as much as I'd like to say it and give an actual number, I generally can't until we get into everyone's individual situation.
Sure. And then you did mention that there are other options too, if you don't have surgery, to look into. So to make it less of a financial burden. Okay. So I want to ask you, so now the surgery is complete. They've gone through everything. They've made this dedication to a new lifestyle and being healthier. What does a dinner look like for someone post-operation? Since I know, it's such a huge change, they kind of have to relearn how to eat. So give us a little insight into that.
Okay, so we'll look at two different phases. The first phase we'll look at is just the recovery phase after surgery, and then we'll look at what is sort of the long-term look like. So in the recovery phase, initially, after surgery, for the first week to 2 weeks, you go on our phase 1 diet, which is a clear liquid diet, which is, juices, broth, jello, starting to introduce protein drinks, basically liquids that go easily through your new stomach so you don't get nauseous, you don't get pain, etc. Once you tolerate that for a period of time, then we do the full liquids, which is where we introduce things like cottage cheese, yogurt, pudding, things with a little bit more bulk, but still go easily through the stomach. The phase 3 diet is kind of soft and pureed foods. So that's where you're introducing like mashed potatoes, scrambled eggs, some, ground chicken, ground beef, more of that thicker consistency. And then phase 4 is when you're back on to eating all different kinds of foods. That process varies from person to person. It usually takes about 3 to 8 weeks to be getting onto solid food after surgery.
Okay.
Once you're on solid food, the goal is small portions and correct food. And so when you're in your weight loss phase, we try to stick to about 600 to 800 calories a day, of which at least 60 grams of protein every day. So that's about 2/3 of your calories. So there's not a whole lot of room for carbs or fats, etc. So for the most part, it's a high protein, low carb, low fat diet. And so while you're trying to lose weight, you really want to stick to that 600 to 800 calories a day, 60 grams of protein. And the other really important part is drinking enough fluid. So at least 60 ounces of fluid every day. For portion size is about 3 ounces. And 3 ounces is about the size of a pack of playing cards. So if you're having some meat, you're having some fish, having some chicken, that's about 3 ounces, which is the size of a pack of playing cards. So that's kind of the thing to remember first. As people are recovering from surgery, 3 ounces may be hard to eat at a time. So you may just have 2 or 3 bites of food, feel full, and that is okay. There's nothing wrong with that. Once you get about 4 to 6 weeks out from surgery, we definitely want you to get at least 600 calories a day, because that's kind of the bare minimum of what you need to survive and function and have energy, etc. It's not to just be on 200 or 300 calories a day. And ultimately, the longer term goal of surgery is not to have to supplement with protein drinks and just have grilled chicken every day. We want a well-balanced, healthy diet, lots of different flavors. You can have different spices, different flavorings, but just sticking to those small portions.
Okay. And emotionally, or, just training themselves of recognizing when they're full, what advice do you give to somebody as they're learning what this means to have a smaller stomach and knowing that they're full?
Yeah, absolutely. So, depending on your age of surgery, people have been trained to eat the same way for 20 years, 30 years, 50 years, 60 years, and it's really hard to break those habits. And so you actually have to give conscious thought to eating after surgery, which you may have never had to do before. So it's simple things like making sure you cut your food into small pieces, make sure you chew it really well after surgery. It's knowing that after a couple of bites, I may need to wait a couple minutes before I have my 4th bite, my 5th bite, so that I don't fill up, I don't feel bloated, I don't end up throwing up. Some people I've even seen set a timer and they say, I'm going to eat for 10 minutes. And then after 10 minutes, I'm done. I'm going to put it to the side and I may come back later. Rather than saying, I'm going to eat everything that's on my plate and finish everything that's on my plate, regardless of however I feel. So that's the mentality we want to get rid of, is just because there's extra food on your plate does not mean you have to eat it. And the other thing I encourage patients is don't get discouraged if you do have that episode where you do eat too much and you do feel nauseous or you even throw up. Everybody has that once or twice after surgery. And that's part of training your body, training your stomach, training your mind to get used to, okay, I realized what I did and I ate too much this time and I need to do it differently. Sure. The other thing we want to do is avoid where we introduce too much gas into the stomach when you're eating. And so it's eating your food first, then having your liquids at the end of a meal. And when you're having your liquids, don't drink from a straw, because that introduces a lot of air. It can make you bloated, make you feel nauseous. And so those are things that we just don't think about. You have a bite of food, you drink water. You have a bite of food, you drink water. Well, you have to separate those two out a little bit.
Oh, that's so interesting. I never knew that. So is there a difference between gastric and bypass? Does one make a difference post-op in that structure of re-eating?
I don't tell my patients anything different in terms of what I recommend for diet between a sleeve and a bypass. For me, I recommend the same diet, the same amount of food. whichever procedure they have. So so technically their stomachs are a little bit different, but functionally it's essentially the same.
Okay. All right. And now I have a question to ask regarding a myth. We hear about people's stomach expanding again. Is that a myth, or does that actually happen if people maybe eat too much food and then it can expand?
So your stomach will never go back to the same size it was before surgery. So that doesn't matter. I think, when people say, oh, my stomach is stretched, and I think what it means is that they can tolerate eating more food as time goes on. And if you remember back to earlier in a discussion where we talked about the hormone changes, where it gets rid of your appetite, you feel full quickly, those changes lessen over time. And so you start to feel hungrier, and then you don't feel as full as quickly, so then you can eat more. And it's not necessarily that your stomach is bigger, it's just you don't have that same effect on your stomach over time. So while you do get those hormone changes, the goal is to be able to modify your behavior so you do start to get used to eating a smaller amount, eating for less time, consuming less calories, and just that being your norm. So that way in the future, your body still says, I'm getting full, even though your body's not triggering it the same way.
Sure. So actually really training yourself to have those different habits in conjunction with the surgery so that it's long lasting. So that goes.
So that's where when we talk about surgery as not being an easy fix, et cetera, is surgery is the tool to help reinforce those important lifestyle changes.
Sure. So what is the likelihood of someone regaining the weight that they once had?
Okay. So if we just look at bare numbers, usually what I quote patients, and we'll just use nice little round numbers. So let's say you weigh 250 pounds and your goal is 150 pounds based on your height. So that would put you at 100 pounds overweight. Mm-hmm. With a bypass, I typically tell patients you lose about 70% of your excess body weight. So that'd be about 70 pounds. With a sleeve, you would lose about 60% of your excess body weight, so about 60 pounds. Mm-hmm. And so if we talk about weight regain, once you get to your goal, the average person will regain about 10% of their weight over a period of about 3 to 5 years. So even if you lose 70 pounds and gain back 7 pounds, you're still in a much better spot over time. Mm-hmm. The risk of failure of not achieving that amount of weight loss or regaining it back is about 30% or less over time. So I would say, overall, when you ask people, did you have success with your operation? 90% of people said they're successful regardless of the amount of weight loss. But if you're looking at weight loss alone, about 70% of people achieve their goal and stay at their goal.
Nice. That's great. I have a question regarding metabolizing alcohol after the surgery. Is this something that changes in people's bodies? I have a friend who received the surgery and now he's like, I cannot metabolize alcohol at all. So can you provide a little insight into that too?
So the goal is not to say that you can never have a drink of alcohol again. But what I always advise patients is when you go back and you have your first glass of wine, your first glass of champagne, your first beer after surgery, it's going to hit you like the first time you ever drank in your life. So even if you could drink 5 or 7 drinks at a sitting, which we don't recommend, but if you could do that before surgery, you definitely are not going to be able to do that after surgery. So number one, the alcohol effect is going to hit you much faster. And it may be that you can have half a glass before you start to feel the effects of alcohol. That may lessen as time goes on, but everybody's a little bit different. The other concern with just alcohol in general is alcohol has a lot of calories in it. And because you can drink a lot easier than you can eat after surgery, it is very easy to consume a lot more calories with alcohol after surgery. And so then people start to substitute the good calories from their proteins, the good carbs, the good fats that they need. And then you start doing alcohol and then you're just getting not good calories, but trying to figure out, well, why am I not losing weight? I'm still doing the protein, but I'm also having 3 or 4 glasses of wine a night, and that amount of calories adds up. And alcohol is like any other beverage. So whether you're drinking sodas, you're drinking smoothies, you're drinking milkshakes, all of those things have a lot of calories in them, and it's much easier to get in those calories that way.
Okay. Yes, that definitely makes sense. Empty calories.
Yeah.
What type of exercises are recommended for patients post-operation?
Any exercise is better than no exercise. The recommendation is at least try to get in 7,000 steps a day. 10,000 is better, but 7,000 is kind of the bare minimum. Lots of people with obesity are limited by arthritis in their knees or their hips, limited by back pain. So you can do low impact activities. You can do chair exercises. You can go, or do aerobic exercise, work out in a pool. You can pretty much do any exercise you can tolerate. The first 2 weeks may be a little bit difficult as you recover from surgery. You get your energy back. The vague aches and pains of surgery go away completely. But pretty much after 2 weeks, you can do any kind of exercise you can tolerate. For patients who may be concerned about extra skin, extra subcutaneous tissue, we think resistance exercises, so using like a resistance band, doing stretches, doing yoga, or doing some high repetition but low weight, that may help to tighten the skin and tighten the muscle up so that you may not end up with quite as much extra or saggy skin afterwards. But in general, a combination between aerobic exercise and weights is usually pretty good for most people.
Okay, great. So it's not an easy road to go down for everyone, but losing significant amounts of weight can have a great impact on someone's physical health and mental health. Have you seen that with your patients, and can you provide a little insight about that?
So you can't pick and choose where you lose your weight. So some people may preferentially lose weight from their face, from their arms, from their belly, from their legs. Everybody's a little bit different. Typically, the first spot we see it is people start to lose it in their face. And then typically the belly from there. But as I said, everybody's a little bit different. It is a change that you go through. You look different, you feel different, etc. Overall, about 70% of people quote that they have some extra skin and fat after surgery, but less than 30% of people actually go on to have what we call body contouring, which is the plastic surgery to remove the extra skin and fat. And that's a wide variety of procedures. It's a paniculectomy, or removing the extra skin from the belly, arm lifts, leg lifts. Some women get breast lifts as well. Insurance will cover some of those. They won't cover all of them. Every insurance company is different as to what they'll approve or not approve. And it's something that we just pay attention to as time goes on if you are having problems or issues. In terms of psychological recovery, people do really well with getting the evaluation before surgery, but it's also just as important for many people to continue that evaluation after surgery to help identify any of those triggers, those stressors, so that you can remain successful as life goes on.
Mm-hmm. And what does that look like as far as the patient-doctor relationship? Do they come in and see you, a year from after their surgery, or when does that patient-doctor relationship continue or stop?
So whenever I operate, I want to see my patients essentially lifelong. And so I see everyone at 2 weeks and 6 weeks just to look for any of the complications, problems, issues after surgery. And then the first year, I see everybody every 3 months. So 3, 6, 9, 12 months. And then typically every 6 months for a year or two, and then at least every year thereafter. So, I want to see my patients 5 years, 10 years, 20 years down the road, because there are certain things that we want to keep track of, see how you're doing, make sure you're not having any problems or your issues. The best visits are the quick visits. That's the patient who says that my weight's staying down, I'm off all my medications, I'm taking my vitamins, I'm sticking to my diet, I'm exercising. Great, awesome. I'm so glad you're doing well. We'll see you back next year. Those are the best visits.
Sure. Well, it sounds like, with such a big life change, it's so important to have that really close doctor-patient relationship, and choosing the right doctor is obviously a very important and individual decision for each patient. So it's great to see, you've been named a patient-preferred bariatric surgeon with 5-star ratings from so many patients. And I can see why, because you're obviously so knowledgeable and really care about your patients. So what does being patient-preferred mean to you?
I like to pride myself on my ability to interact with patients, to educate them, to make sure they have good results. And so I think it just helps reinforce that what I'm doing is paying off, and that people appreciate that what I'm doing.
Yeah, well, definitely. And changing so many big things in people's lives must be very rewarding.
Yeah, I enjoy it. It's very different. I have kind of 2 parts of my practice. I do a lot of emergency surgery, which is people coming in with gallbladder problems, appendicitis. We operate, they get better, you see them 2 weeks later, and then they move on, which is great because it's nice to really make an impact on someone who's sick and get them better. But with my bariatric patients, I get to see them over time. And so I kind of get all the different benefits of medicine, to both get the short-term fix as well as the long-term results. So I really enjoy that about my practice.
Nice. So before we wrap up, is there anything else you want to touch on about bariatric surgery before we end our discussion today?
I think kind of what we've hit on all the high points. It is a great operation for the right person. But one of the keys that we always want to do with our evaluation is make sure, we're choosing the right patients, and the patients are choosing me to make sure that we're proceeding and that everyone's comfortable with what to expect both before and after surgery.
Nice, definitely. So we answered a lot of questions here today. And for anyone considering bariatric surgery, I hope it provides some additional insight and knowledge. And I hope our audience learned about how having these surgeries for weight loss can have a positive impact on your overall health, and not just about fitting into a bikini or looking good. So for most people struggling with weight issues, it goes much deeper than that. So I want to thank you so much for sharing your time with us today, Dr. Sutker, and for giving our audience and for those considering this procedure, your expert advice and helpful insight of weight loss surgery. I know I learned a lot today. And what do you say? Maybe next time you can join us for a Q&A, because I'm sure our viewers have more questions they'd love for you to answer.
Absolutely.
Wonderful, wonderful. All right. Well, thank you all for tuning into Talking Points with Preferred Health Magazine. Until next time, stay safe and in good health.